Good afternoon and welcome to today's presentation, You Are the Key to HPV Cancer Prevention. The webinar is being hosted by the California Department of Public Health and the California Statewide Area Health Education Center program. Before we begin, I'd like to instruct you on how to access the audio and submit questions to our presenter today. I've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer. You're listening in using your computer's speaker system by default, as shown in the upper left red rectangle. If you prefer to join over the phone, just select telephone in the audio pane as indicated in the red rectangle to the right, and the dial-in information will be displayed. You will need to enter the access code and PIN provided. The orange arrow, which I am indicating with my mouse right here, allows you to minimize and maximize the control panel throughout the presentation. After the presentation, we will have a Q&A session. At any time during the presentation, you may submit a text question by typing your question into the questions pane of the control panel indicated in the lower red rectangle. We will collect these and address them during the Q&A session at the end of today's presentation. During the Q&A session, you may also raise your hand to ask a live question by clicking on the hand you see circled in red. Please note that in order to ask live questions, you will need to have joined the webinar via telephone and have entered the access code and PIN provided. If you raise your hand, we will unmute your line for you to ask your question. Now on to our presentation. We are honored to have Dr. Mark Sawyer presenting to us today. Dr. Sawyer is a professor of clinical pediatrics and a pediatric infectious disease specialist at the UCSD School of Medicine and Rady Children's Hospital, San Diego. He is the medical director of the UCSD San Diego Immunization Partnership, a contract with the San Diego County Agency for Health and Human Services to improve immunization delivery in San Diego. He is a current member of the American Academy of Pediatrics Committee on Infectious Diseases and the FDA Vaccines and Related Biological Products Advisory Committee. Dr. Sawyer is a past member of the CDC Advisory Committee on Immunization Practices. He and his 3 children are fully immunized. With that, I'd like to turn it over to you, Dr. Sawyer.
Thanks very much. It's a pleasure to join you all today and help spread the word about HPV vaccine and HPV cancer prevention. This topic is quite timely since President Obama in his State of the Union address announced a new initiative across the country to combat cancer. And on an interview I heard on the radio this morning, a cancer specialist pointed out that 50% of cancers are preventable. And that certainly includes the cancers that we can now prevent through HPV vaccine. So today we're going to cover a number of topics related to the burden of HPV disease, the importance of vaccination, and some tips about communicating about HPV vaccination so that we can better protect our community from cancer. I have no financial disclosures to make related to this presentation, and the objectives for today specifically are at the end of this presentation you should be able to define the importance of HPV vaccination for cancer prevention as well as the rationale for starting vaccination at age 11 or 12. Specifically be able to list the recommendations and differences in recommendations between girls and boys. Provide compelling information about HPV vaccine to parents so that we can improve their acceptance of this very important vaccine. And finally, we'll help you locate some resources that can help with this effort. So I summarize this entire topic with 3 statements, 3 reasons you should care about HPV vaccine. First of all, HPV causes lots of cancer, and I will show you the numbers to support that statement. HPV vaccine prevents cancer because it prevents HPV infection very effectively. And unfortunately, at this point, we are doing a terrible job of immunizing our population with HPV vaccine to prevent cancer. And of course, that is really the purpose of this webinar and other programs around the country to try and improve our ability to prevent cancer through delivery of this important vaccine. So let me give some basics about HPV and how it relates to cancer. There are many, many types of HPV virus that infect humans. Most of them are not very important. As you see in this slide on the right-hand side, a lot of HPV serotypes only cause cutaneous infection and are mostly an annoyance in the form of common warts that we all get. The important types are shown on the left. Those are the ones that infect mucosal surfaces, and particularly HPV 16 and 18, which is the most common oncogenic or cancer-causing strains of HPV, and they lead to the cancers shown in the red box. There are also mucosal viruses, including HPV 6 and 11, which cause genital warts and laryngeal papillomas, which are related problems that are quite common, particularly genital warts. And we have the potential now to prevent these mucosal site infections through vaccination. HPV is a very common infection. Most people will be infected at one type during their life. Estimates are at this very moment 79 million Americans are currently infected. There are 14 million new infections every year, and HPV is the most common in people in their teens and 20s, and in fact it's the most common sexually transmitted disease. Most people, however, never know that they've been infected, and that's one of the challenges in communicating to our patients about the importance of HPV vaccine. Early on, HPV vaccine is without any symptoms, and we only know it's there if we actively go looking for it. Eventually, though, the changes in the cells that are induced by HPV lead to precancerous changes, so-called CIN or precancers. These are the precancerous changes that we hope to catch by pap smear examinations in women and treat them before they progress to frank HPV-associated cancers. That progression takes many, many years or decades, and this is another challenge for communicating about HPV, in this case communicating to physicians who care only for children, pediatricians. They never see the consequences of HPV infection, and so it's hard for them to get as passionate about this topic as healthcare providers who care for adults who do see HPV-associated cancers manifest decades after the original infection. Again, this is a very common infection, something on the order of 27,000 people diagnosed with cancer related to HPV every year. That's one case every 20 minutes. And these numbers are important, and I'll put them in context a little later compared to the other diseases that we try to prevent in adolescent populations. Here are the numbers broken down by sex, male and female, and also the various cancers on the left-hand side of this table. You can see that there are thousands, in most cases, thousands of cases. And on the far right-hand side of the table shows the percent of cancers in those different sites in the body that are caused by HPV. And as you can see, for all of these cancers, the majority of cancers in those sites are due to HPV. And in the case of cancer of the cervix, over 90% of cervical cancer is related to HPV infection. All of these cancers are now potentially preventable through the use of vaccine. Cervical cancer is the most common cancer associated with it, and most people know of this as a vaccine that prevents cervical cancer, but it's important to remember that table because many other cancers are prevented as well. This is not just a problem in the United States. This is a worldwide problem with over 275,000 deaths per year, at least in 2008. Many of these cancers do occur in younger women, although it can take decades for them to manifest. As you can see in the lower part of this slide, 13%, nearly 1 in 8, occur in women between age 20 and 34. There's also some ethnic and racial disparities with regard to rates of cervical cancer, with African American and Hispanic populations being at increased risk. Some of this may have to do with access to care and good cancer screening, but there may also be some genetic predispositions that lead these groups to have an even higher rate than the average for the cancers caused by HPV. So that leads us into the section of this talk where we discuss the vaccine. Talk to your doctor about vaccinating your 11 and 12-year-olds. That is the platform that we're all trying to promote, and I'll go through some information to explain why that is the key age group for immunization and the important for us to start. So first, a little bit about the HPV vaccines. These are a unique type of vaccine, so-called, they're made up of capsid proteins, and when these proteins are put through the manufacturing process, they actually form virus-like particles, which there's a graphic to depict what they might look like. It turns out, from an immunologic point of view, virus-like particles are very effective. Your immune system essentially thinks that they are real viruses, and they respond in a very broad and strong way, and that has led to the great success of these vaccines. These are among the most successful of all vaccines that we have, and they produce higher titers than even natural infection. As you probably know, there are now 3 different HPV vaccines on the U.S. market. The bivalent HPV vaccine, which contains serotype 16 and 18, the brand name Cervarix. The quadrivalent vaccine with type 6 and 11 added to 16 and 18, that's the brand name Gardasil. And the newest vaccine on the market, the 9-valent vaccine, which adds 5 additional serotypes to the previous vaccine made by that same manufacturer. The dosing sequence is very similar for all of these vaccines. It is anticipated that the quadrivalent vaccine will fade out of the market and to be replaced by the 9-valent vaccine, which just within the last month was approved by the FDA for use in males all the way up to age 26. So I anticipate within this year that we will lose the quadrivalent vaccine and be left with the bivalent and the 9-valent vaccines. This graphic shows the importance of these different vaccines and what they can prevent and the serotypes contained within them. So first focus on the blue circles, 16 and 18. Again, those are the most common serotypes that lead to cervical cancer, causing overall 66% of all cervical cancers are caused by just those 2 serotypes. On the left-hand side shows the serotypes caused by genital warts. Those serotypes are contained in both the quadrivalent and the 9-valent vaccine, but not in the bivalent. And then the new change is shown on the right in the purple circles. 5 additional serotypes of HPV have now been added, and these will allow us to prevent an additional 15% of all cervical cancers. So although HPV vaccine is very effective, it will not prevent every single cancer, but we're getting to the point now where we can prevent over 80% of cervical cancers by using the 9-valent vaccine. What we know about the vaccination is that it's safe, that it works, and the duration of immunity is good. These are all concerns that you hear about from patients and in some cases from physicians. We know that the benefits of vaccination far outweigh the risks, and we'll talk more about safety studies that have informed us about that. We now have evidence that these vaccines are preventing not only infection, but also the precancerous changes that result from infection. And we now have pretty good evidence for long-lasting immunity for this vaccine. So those are all things that you hear about. You can address those with your patients when they come up. Let's just review the ACIP recommendations. There's a routine vaccination recommendation at age 11 to 12. That's for both boys and girls. For females, vaccination is recommended all the way up through age 26, and for males up through age 21 who have not previously been vaccinated. There are high-risk groups in the male population who should continue to get the vaccine also up to age 26. These are men who have sex with men and immunocompromised persons. The bivalent vaccine is not recommended for males currently, only the quadrivalent and the 9-valent vaccine for males. For females, any of the vaccines have been approved and recommended. Recommendations were recently updated to accommodate the new 9-valent vaccine and the transition from the 4-valent to the 9-valent. For females, any vaccine product can be used, so if you have a patient who's already received 1 or 2 doses of either the bivalent or the quadrivalent vaccine, you can transition them to the 9-valent vaccine and give the 3rd dose as the 9-valent vaccine. For males, same thing applies. If they've already had quadrivalent, you can continue the series with the 9-valent vaccine. You do not need to start over on the series. The timing is again similar between all of the products, but the interval between the first 2 doses is 1 to 2 months. The interval between dose 1 and dose 3 is 6 months. If the vaccine schedule is interrupted, you do not need to restart, even if it's been years since the first and second doses were given. You just need to complete the series. Some of you may have heard about a 2-dose regimen for HPV vaccine. That is used in some other countries. In the United States, the 2-dose vaccine schedule is not yet recommended, and the vaccines are not approved by FDA for this purpose. But I do anticipate that we will see that coming forward in the next couple of years, and it will be important to remember when that happens that if you're only giving 2 doses, they need to be spaced apart by 6 months to have a good effect. So stay tuned for those developments in the coming years. I want to now turn attention to HPV vaccine safety. There's been a lot written in the lay press, and this is a common concern of parents when the discussion happens about vaccinating their children. And with all vaccines, we need to look at the risk and benefit ratio. There are a number of data points that we have now to reassure our patients that this vaccine is safe. The Vaccine Adverse Event Reporting System has been collecting data for nearly a decade now about administration of HPV and possible side effects after them. There are no serious side effects that have been shown to be effective. The one thing that definitely is related to HPV vaccine is syncope or fainting. And that's why there is a recommendation that you, following vaccination, you adhere to a 15-minute observation period in your office or clinic before you let the patient get up and walk out of the clinic. There have been some serious injuries related to fainting, and so this is something that really should be followed with HPV vaccine in particular. Now, in terms of the data we have now about vaccine safety, I want to let you know about a program called the Vaccine Safety Data Link, the VSD, which is funded by CDC. It's been in place for a number of years and allows us to really answer scientifically questions about vaccine safety. The Vaccine Safety Data Link is a grouping of managed care organizations such as Kaiser, which follow literally millions of patients at one time and have electronic health records so that you can look following HPV or any other vaccine and determine in large numbers of people whether there are side effects, including very rare side effects. So there's a recent study that's referenced on this slide of 600,000 doses of HPV, the quadrivalent version of HPV in females, with no significant risk identified, and specifically they were looking for things that people had brought up as possibly related: Guillain-Barré syndrome, seizures, syncope, which we have found for sure, and some of the other items listed on this slide. Again, none of these things were found to be relevant to HPV vaccine administration. There are ongoing studies that are occurring as we speak by the manufacturers and others. The safety of HPV has been reviewed by the World Health Organization and the Institute of Medicine, and once again, no serious adverse effects have been related to this vaccine. This slide shows 3 specific side effects that people had wondered about: venous thromboembolism, autoimmune disease, and injection site reactions. Again, these were not found to be associated with HPV vaccine. So we really do have very robust data that confirms the safety of these vaccines. So let me remind you, the 3 reasons you should care about HPV. It causes lots of cancer, HPV vaccine prevents cancer, and we're not doing a very good job. So let's talk about how we know that HPV vaccine prevents cancer. Well, here's data from the National Health and Nutrition Examination Survey, which is an ongoing CDC project that looks at a variety of health outcomes. In this case, they compared HPV infection as detected by actually doing PCR on samples, genital tract samples from participants in the survey. They compared the rate of HPV infection in the pre-vaccine era, that's 2003 to 2006, with the rate after the vaccine was initiated, 2007 to 2010. And keep in mind, at that point in time, we had relatively poor uptake of the vaccine. We were just starting the program. Despite that, as shown in the results section, In 14 to 19-year-olds, there was a 56% decrease in the rate of HPV infection. That gives an estimated vaccine effectiveness of 82%, which is pretty good compared to many vaccines that we give. Not only that, we could see the clinical impact of the vaccination. This is data from insurance companies looking at prevalence of genital warts. And if you find the red line in the middle of all those different colored lines, that is the rate of genital warts in 15 to 19-year-olds. That's the age group that should have benefited from the vaccine when they received it starting at age 11 to 12. And as you can see, in that age group, and only in that age group, from 2007 to 2010, there was a noticeable decrease in the prevalence of anogenital warts. So the vaccine works. It prevents infection. It prevents the clinical consequences of infection, in this case, anogenital warts. Here's a similar study from Australia showing the same thing when they initiated vaccination in 2007, shown by the dotted line on both of these graphs. In both males and females, there was a significant decrease in the rate of genital warts in the youngest population, that is, people under 21, who are the ones who did receive vaccine and would benefit from that. So there's no question that the vaccine prevents warts. There's also been multiple other studies. They're reviewed in this particular reference shown on this slide, over 20 studies from countries using HPV vaccine. In countries that have good coverage rates, greater than 50%, again, a decrease in the prevalence of HPV infection, in this case of 68%. So there's no question that these vaccines work. They may even provide so-called herd effects. That is, even people who are not vaccinated may gain benefit if their partners are vaccinated. And there is also some evidence of cross-protection against some of the serotypes that are not in the vaccines but are related to the serotypes in the vaccine. So altogether, this is good news that these vaccines really do have an effect. Now, many physicians have expressed concern about duration of immunity, and that's something I hear from people as a rationale for delaying the start of HPV vaccine. Now, it is true that in the United States we've only used this vaccine for a decade, so that is the strength of the data we have so far. But there's no evidence of waning immunity over that decade period of time in people who are vaccinated early on in the HPV vaccine program. So we have every reason to believe the vaccine immunity will have long-lasting effects, and therefore there is no reason to delay starting the vaccination at 11 to 12 as it's recommended. So HPV causes lots of cancer. The vaccine prevents cancer. Now let's look at the terrible job we're doing in immunizing our population with HPV vaccine. Here's a comparison of the 3-dose HPV vaccine coverage in Australia, the United Kingdom, and the United States. As you can see, we are lagging way behind those other countries in getting our girls immunized with 3 doses of vaccine. We are only in the 30 to 40% range, despite the vaccine being available and recommended for close to a decade. So we need to do much better to protect those other 60 to 70% of women from getting infected with these viruses and eventually getting cervical cancer and the other cancers caused by HPV. This graph shown that was published in the MMWR just this year in 2015 shows the accumulated coverage over the last 8 or 9 years in the United States, and it compares it to the 2 other vaccines we give to adolescents routinely, TDAP, which is in the solid blue line at the very top, and the meningococcal conjugate vaccine shown in the dashed line, the second one from the top. You'll notice that there's a big difference between our coverage rates for Tdap and meningococcal vaccine compared to HPV. The single dotted line, the third line from the top, is the rate of coverage with just 1 dose of HPV vaccine in females. And 1 dose alone is not going to be sufficient to protect women from infection. We need to get 3 doses in, and here again you can see we're in the 30 to 40% range for females, and we're even less than that for males because we started that program later. So we have some catching up to do. This graph shows you what we should be able to accomplish if we just gave HPV vaccine every time we give the other vaccines to adolescents. That is, adolescents who are in their doctor's office or clinic getting Tdap vaccine and meningococcal vaccine. If we had given HPV vaccine at the same time as we gave the other two, we would be achieving a 91% coverage with at least one dose of vaccine. So there's something happening during these visits where the other routine vaccines are given and HPV vaccine is not. And we're going to spend most of the rest of the talk discussing why that happens and some communication tips that you can follow to hopefully keep that from happening in the future. So it's really all about framing the conversation, the way you deliver the message, and the strength of your recommendation for HPV vaccine makes all the difference to compliance and is what we need to change in order to get our rates up to those of the other countries that are using this vaccine. So there's a number of reasons this is happening. One is that physicians sort of underestimate the importance that parents place on vaccines. This is shown in a study by Mary Healy published in Vaccine. This is a survey of both the parent and the provider about their feelings of the importance of the various vaccines you see along the bottom of the graph. For most vaccines, the provider and the parent are on the same page. They all feel that the vaccines are important. For HPV vaccine, the parents also think that vaccine is important, but the providers estimate the parents have placed less value on HPV vaccine. And that's because they've heard a number of stories from some of their patients. They've read in the media about people being concerned about this vaccine, that it's too new or that it has side effects or that it's not important. So we have a mismatch between the provider's estimate and the actual parent perception of vaccine. So parents are interested in this vaccine, and as has been studied many, many times, the most important person to convince a family or a patient about vaccination is their healthcare provider. If you give a strong and forceful recommendation for this vaccine and any other, the vast majority of people will follow that recommendation. So that's what we need to achieve. Here's a study published in the MMWR showing reasons why parents had not chosen to have their child immunized, and you can see 5 reasons here listed on the graph. Not that their adolescent was not yet sexually active, so it wasn't needed, that it was not recommended, and that is highlighted because that's our job as providers, is to recommend the vaccine. A significant percent had safety concerns. Some thought it was not needed or necessary. Again, that falls on the provider to educate our families about why it is needed and necessary. And again, lack of knowledge. So many of these things, many of these reasons why parents don't get immunized can be solved simply by the provider educating them, showing and demonstrating the importance, and making a strong recommendation. That is the most important thing that I think we can accomplish here. So we need people to come up with strategies to really make that effective recommendation. And in general, the feeling is amongst people who've studied communication around health issues is that you need to recommend HPV vaccine the same way you recommend Tdap and meningococcal vaccine. It shouldn't be singled out in the conversation. You should recommend them all on the same day. You should recommend them as all routine, and give a strong recommendation for all of those vaccines. You certainly should answer questions that parents have, but you shouldn't invite questions by singling out HPV as somehow different than or less important. And to reinforce that for you, I put this slide together showing deaths from vaccine-preventable disease. This is just in 2014 in the United States. We spend a lot of time discussing Tdap and meningococcal vaccine, but as you can see, they are really responsible for a very small number of deaths in the United States compared to influenza, which we're not talking about today, but another important vaccine for adolescents. But look at HPV-related cancers, 4,000 deaths a year. So it's unclear to me why providers don't endorse HPV vaccine with even more enthusiasm than they do pertussis, Tdap, and meningococcal vaccines. So here I'm going to go through some examples of communication styles that have worked for some people. Overall, you want to lump the 3 vaccines together as illustrated in this Quote, Sophia's due for 3 vaccines today. These will help protect her from meningitis, HPV cancers, and pertussis. We'll give those shots at the end of the visit. People who've looked at this question feel like you shouldn't leave HPV to the end of that list, maybe even put it first, again, so that it's not singled out as somehow less important than the other 2 vaccines. Now, I know that you've all heard various concerns voiced by families about this vaccine and the vaccine series, so there's a series of slides here that can now help you with some communication tips about how to address those concerns. So for example, my daughter will wait for marriage, she won't be exposed, so it's not necessary. Well, you need to remind and educate families that HPV infection is so common that almost everyone gets infected at some time, and that when their daughter does get married, she could get the vaccine from her husband, and they can't just start the immunization series once they get married because it takes, again, 3 doses to be fully effective, and that there is no way for them to know whether the future husband might have been infected before, or vice versa for that matter. If the main concern is why now, it seems too soon, let's wait until the child is older, there are a couple of things that you can share with families. First of all, we do know that the vaccine immune response is actually better in younger teenagers than it is in older teenagers. I don't know why that is the case, but that's been shown in a couple of studies now. The antibody levels that you induce are higher in younger adolescents. And that's one reason that some parents will accept as a reason to start early and dodges the question of sexual transmission and when their adolescent is going to engage in sexual activity. So speaking of that concern, HPV vaccine will be a green light for sex. You hear that from some parents, although really, I mean, adolescents usually are not that deep in their thought processes that they're worried about a specific infection with HPV as a reason to not become sexually active. But there have now actually been studies that have looked at this. One that is one of my favorites was done by Kaiser, and looked at what happens when you start sexual activity. You either get pregnant or you get a sexually transmitted disease or you seek out birth control. And again, using their electronic medical record, they were able to show that those outcomes were no different in girls who'd been immunized with HPV vaccine compared to those who had not. So HPV vaccine is not a green light for having sex, and we can even say that scientifically now. If the main concern is would you give it to your child, if the parent probes you about that, then of course I'm hopeful that you have, if you have children in the appropriate age, and that's an important tip for any vaccine when you're dealing with a vaccine hesitant family, is point out your own personal endorsement of the vaccine by illustrated by the fact that you yourself and or your family are immunized. Now, there are side effects with HPV vaccine, as there are with any, and some of those side effects have been overstated in the lay press, and parents come in with concerns. So we do have to acknowledge that vaccines, like any medication, do have side effects, but that the ones associated with HPV are minor and transient, and that all of the potentially serious side effects that have been postulated have now been disproven in scientific studies, and that there is no link between HPV vaccine and any serious or long-term side effects, and that is true around the world. There are some populations who have heard within their community that HPV vaccine may cause sterility and have effects on fertility. Again, there's no data to support this. In fact, the opposite is true. If you have HPV infection, instead of preventing that infection through vaccination, then cervical cancer, of course, is going to impact your ability to have children, and even the treatment for the precancerous changes sometimes disrupt the normal patency of the cervix or competency of the cervix and can cause preterm delivery and other problems with pregnancy. So if you hear this concern voiced by families, you can actually counter it by saying, well, you know, in fact, the opposite is true. If you get HPV infection, you're more likely to have problems with subsequent pregnancies. So we've talked a lot about vaccine coverage and pointed out that we're not doing a good job, and that we are particularly not doing a good job at getting all 3 doses of the vaccine in. So it is important to remind families that they need to come back and complete the series. You should make appointments for the next shot in the series before the patient leaves the exam room or leaves your office, so that we can optimize the chance for good compliance. Again, I'm hopeful that in the next year or so we may have a 2-dose regimen that we'll be able to use, which will make it a little bit easier to complete the series. But for now, 3 doses are required, and it takes therefore 6 months to get all of the doses in. And it's important to get all the doses in before adolescents become sexually active. The vaccine does not have any effectiveness after the fact. In other words, if you're already infected with the serotypes that are in the vaccine will have no benefit. So it's very important to get all doses in before. So let's just go over some review questions that summarizes the key discussion points today. So first review question, HPV vaccine is recommended for the following persons: all adolescents at 11 to 12-year-old visit, females only at a 13-year-old visit, males only at 11 to 12, or females only at 11 to 12. I'll give you a second to think about it. And now we'll move on to the right answer, which is all adolescents. Now, we started out the HPV vaccine program immunizing females only, but now males have been in the group who should be routinely immunized for several years, and again, we're lagging behind in getting our adolescent boys caught up with vaccination. Why should males receive HPV vaccine? To prevent infection with HPV type 6, 11, 16, and 18. B, prevent genital warts caused by HPV 6 and 11. Prevention of anal cancer caused by HPV type 16 and 18, or all of the above. Let you think about it for a second. And obviously the answer is all of the above. So males get a variety of different cancers. They do also get genital warts. In fact, most adolescents who know about genital warts would absolutely prefer to get the vaccine than have that particular problem. So it's not too hard to convince adolescents about the importance of these vaccines. So review question number 3, which of the following HPV vaccine recommendations for a child aged 11 or 12 years is the most likely to be successful? A, ask the parent if the child is sexually active and then discuss the importance of HPV vaccination. Tell parents that their child needs 3 vaccinations to prevent meningitis, HPV cancers, and pertussis. Tell the parent about the vaccinations that are mandatory for school entry and ask if they also want HPV, and at least in California and most states, HPV vaccine is not required for school entry. And D, ask the parent if they want to get HPV vaccination for their child or wait until the child is older. So clearly the answer, as we've covered in the presentation, is to lump HPV vaccine recommendations in with the others as routine and strongly endorsed by you as a provider. All 3 of these vaccines are important. If you wait till adolescents are already sexually active, it may be too late, so it's important to get started early. There's lots of resources available at CDC and also at the California Department of Public Health, and there's a portal which is the URL is listed here, cdc.gov/vaccines/you are the key. You can get a number of materials there, and here's an example of some of the continuing education modules that are available through CDC and other sources, and you can access those if you or your colleagues would like additional information about HPV vaccination and the importance of framing the recommendation in a positive and forceful way. There are fact sheets available at CDC. Some of them are illustrated here in English and Spanish that again explain to families in lay language about the importance of these vaccines and why they're recommended routinely. And here are 2 posters that are available again through the CDC website that you can put up in your office that make some of the points that we've covered today and make them available for your patients to get that information as they're having their visit in your clinic or office. For additional resources, if you want to know when new resources are developed, you can register through email at preteenvaccines@cdc.gov, and they will update you on new materials. They will also have a speaker program similar to this presentation you're hearing today that they could provide speakers for your local medical groups or grand rounds presentations and other continuing education events. So that's the end of my part of this presentation. I'm going to turn it back over for information about completing the program evaluation, and then we will take questions and answers.
Thank you so much, Dr. Sawyer. Before we begin the question and answer session, I'd like to bring your attention to the evaluation and continuing education links. Please complete an evaluation of this afternoon's webinar using the first link, bit.do/HPV eval. If you would like to receive continuing education credit, and that includes CME or CNEs, or a participant certificate, which is for behavioral and public health professionals. After completing the evaluation, you will also need to complete the survey at bit.do/HPVCE. Both of these links will be provided in the follow-up email sent to participants after the webinar. We will also be sending these out over the chat, so you can access those links directly that way. It is now time for our Q&A session. You may submit a text question by typing your question into the questions pane of the control panel indicated in the bottom red rectangle. You may also raise your hand to ask a live question by clicking on the hand that you see circled in red. Please note that in order to ask live questions, you will need to have joined the webinar via telephone and have entered the access code and PIN provided. If you raise your hand, we will unmute your line for you to ask your question. Our first question is, what do you recommend for girls or boys previously immunized with HPV-4 now that HPV-9 is available? Should they be revaccinated?
Yeah, that's a good and very common question. At this point, the CDC has not come forward with a recommendation to re-immunize individuals who've already completed the series with the one of the previous vaccines, either HPV-2 or the HPV-4. And the part of the reason for that is that CDC, I think rightly so, has pointed out that we're not even doing a good enough job getting the current 3 doses of any of these vaccines in. So to divert attention and resources to re-immunizing people who already have protection is not thought to be an effective strategy from a public health point of view. Now, on an individual basis, the vaccine, the 9-valent vaccine, has been studied in people who've already had the 3 doses of the previous vaccines, and it appears to be safe, and it likely would be effective in adding protection for that 15%. So I think at some point we may see a recommendation to re-immunize or catch-up immunize people who've already been vaccinated, but at this point there is no such recommendation.
Our next question, can you say more about the incidences of syncope following vaccine administration?
Yeah, this was a bit surprising when this vaccine was first licensed and started to be used. This vaccine does cause a fair amount of discomfort as it's being given, some burning or stinging, and adolescents in general, when they're subjected to painful stimuli, are more likely to faint than younger kids or adults. And the same phenomenon has been seen with other vaccines. It's not unique to HPV, but it seems to be more common or prominent with HPV vaccine. And as I mentioned earlier, there have been some serious head injuries that have occurred in people who have fainted and hit their head on a hard surface on the way down. So it is important to observe patients, leave them sitting or even laying down on an exam table for 15 minutes after vaccination. If you do that, the problem seems to no longer be an issue. So it is recommended that you follow that observation period and not just give the vaccine and send your patient out the door immediately.
And next we have a live question. So Chin, your line is now unmuted if you'd like to ask your question. Okay, we'll go to one of our text questions. If a patient receives the second dose 5 months after the first, what is the spacing between the second and third dose?
I have to look it up to be absolutely sure, but I think there's supposed to be 16 weeks between dose 2 and dose 3. That kind of information is available at the CDC website. There is a table that's available in the publication called General Recommendations for Immunization, which shows the minimum intervals between doses of any vaccine. But it is important to remind everybody that you do not need to start the series over for any vaccine. If there's been a longer than normal interval between doses, that's okay. The only problems we see are when immunizations are given too close together, not when they're given too far apart. So again, I'm not confident of the absolute interval, but it's on the order of 16 weeks between dose 2 and dose 3.
Next question. What did the UK and Australia do to get a better uptake of HPV vaccine?
Yeah, I don't actually know in Australia, but in the UK I do know they have a very effective school-based immunization program for adolescents. So they take advantage of the fact that they have a captive audience in schools, and they go in with vaccination, I think, provided by public health personnel in the school setting. And so they very quickly went from not just starting the vaccination to a coverage rate that I showed you. And the same has been seen with meningococcal vaccine and Tdap vaccine in the United Kingdom, or at least Tdap vaccine, which they give routinely to adolescents. And they also have much better coverage rates than we do, and achieve them much faster. So this is something that's been talked about in the United States. There are lots of logistical barriers to school-based immunization programs here, but it is something that I think we should continue to think about and explore, because there's certainly no doubt that's one place you can find lots of adolescents.
Next question. Would having an educator in the waiting room promoting the vaccine be helpful for decreasing vaccine anxiety among parents?
That's an interesting question. I can sort of see two sides to it. Again, I think the overall strategy with HPV vaccine is not to single it out and have it just be considered routine. So you might have an educator who would provide information about all vaccines and not just HPV vaccine. But I think that may or may not be feasible for lots of organizations and clinics to have somebody like that available. I think the simpler thing is if we just get providers to make a very strong recommendation. There is lots of literature that supports the fact that patients and parents will follow a provider recommendation when it's given. And so I think the easiest thing for everybody to raise their rates is to simply make the recommendation for HPV vaccine routine and make it forcefully, and that's going to probably do more than anything else to improve your rates.
Thank you. The next question asks if the presentation will be available in PDF for download so it can be shared with staff. And I can answer this one, Dr. Sawyer. Yes, the webinar will be archived on easyiz.org. I will also send an email out to all registrants, including participants, in the upcoming days. But yes, we will archive the webinar and also make the PDF slides available. And the next question is, if the patient has a syncopal episode with the second dose, what is the recommendation for the third dose?
It would be certainly to continue to vaccinate. Again, this is not something that builds into a more serious side effect with subsequent doses, that would certainly be a patient that you might even extend the period of observation to, say, 30 minutes after vaccination just to be sure. But this is not this would not be a reason or contraindication for subsequent vaccination. You should go ahead and give the third dose at the normal time.
And our next question, is there any data that HPV vaccination prevents oropharyngeal cancers?
I don't think there's evidence yet that has shown that. There are studies ongoing to look at that question. So at this point, we're basing the assumption that oropharyngeal cancers will be prevented based on serologic and immune data that show that males and females do get good antibody levels against the types of HPV virus that cause oropharyngeal cancers. But I think it's going to be a little longer before we have direct evidence. And again, we're just now getting direct evidence that it prevents cervical cancer and the precancerous changes. So every expectation is that these vaccines will prevent all HPV-related cancers, at least for the serotypes that are in the vaccine.
And we have another question. What if the patient develops a severe allergic reaction to HPV vaccines?
Well, that would be the same approach that for any vaccine. So a severe allergic reaction is a contraindication to subsequent doses of vaccine. If by severe reaction we're talking something anaphylaxis or similarly severe reaction. Now, this vaccine is not made in eggs, and so egg allergy, that kind of reaction would not be a contraindication. But if with a previous dose of this vaccine or any other vaccine for that matter, if someone develops a severe allergic reaction, then they should not receive subsequent doses.
Okay, at this time we have no further questions. In that case, this concludes our webinar. Thank you so much for joining us today. The webinar, as I mentioned, will be archived on eziz.org in the upcoming days. Thank you so much for your participation. Have a great day.